Welcome, my trailblazers. Welcome to the DigiPath Digest number 42. We've met already 42 times to discuss abstracts about digital pathology and medical AI.
Learn about the newest digital pathology trends in science and industry. Meet the most interesting people in the niche and gain insights relevant to your own projects. Here is where pathology meets computer science. You are listening to the Digital Pathology Podcast with your host, Dr. Alexandra Zhurov.
It's Easter edition of the live stream, and let me give you a few updates. So happy Easter, everyone who's celebrating Easter. I hope you have a fantastic Easter time. The last conference was USCAP, and let me know in the chat if you've tuned into the streams, because they were pretty popular. The conference live streams are pretty cool. People like them. People who were there came to the Hamamatsu booth. We had the book giveaway. There was, I don't know how many books I've given away, but definitely over 30 books. I have signed them. And if you have not gotten a book, you should see a QR code on the screen. When you scan it, if you have not joined the list of digital pathology trailblazers, you can join it and get the free PDF of the Digital Pathology One-on-One book in the process. It's going to come into your inbox, and then you will get all the updates about what's happening at Digital Pathology Place, including the announcements for conference streams, different things like book giveaways, or whatever else we are organizing together with Digital Pathology Trailblazers, maybe meetings in person, whatever if we do. So the highlight, well, there are many highlights, but one cool thing at USCAP, other than working together with Hamamatsu on showcasing their partnerships, so that was actually part of these partnerships, was with an lab automation company, Ether AI, I think you pronounce it. I'm going to show you the robot that they have after we review one paper where they mention actually robots. So if you don't have the book, get the book, and we will have an Easter discount code to the store, but I'm going to show you the discount code after we review some papers, because we have 5 abstracts to review today. So let's just start with deep learning can predict the overall survival of cervical cancer based on histopathological image, gene mutations, and clinical information. And let's just highlight. We have a couple of things, right? It's not just prediction from histopathology. We have histopathology, gene mutations, and clinical information. So let's see how that went. Did they actually do it? Did they not do it? They did it to a certain extent, otherwise they would not be publishing. So the fusion of data features from different modes like pathology images and sequence data has the potential to predict overall survival of patients with cervical cancer. And that is like, we want to know how the disease is going to behave in the future. So that's what they like try to extract out of these multimodal data. And they developed a novel prediction model for overall survival that incorporates pathology images, clinical data, and molecular data. And the model underwent training using the Cancer Genome Atlas, TCGA. So that's interesting because they used TCGA for training, and they included 119 patients, but then they independently validated the model, and they used data sets from Peking Union Medical College Hospital. So they had real not hypothetical, the TCGA patients, TCGA data for training, but then they used a totally independent validation set of 53 patients with cervical cancer, and they identified with Lasso-Cox regression, they identified relevant features associated with overall survival. And what were the relevant features were apparently a lot of genes, 484 genes, including RGR, DBN1, and CalCR or CALCR, but also a lot of image features. And so they found these like relevant features, and then they used the relevant features to build this multimodal deep learning model to effectively classify the overall survival of patients with cervical cancer into 2 categories. short-term and long-term. What is short-term, less or equal to 3 years, and long-term is over 3 years. And so here we have to pay attention because it was based off integration of pathology images and clinical features. And they developed a model with reasonably good prediction accuracy, AUC 0.783. And they say, so I'm going to reveal this like mystery that's coming across in this abstract that I would have not picked up on if I didn't listen to the AI podcast, AI paper summary that I created. I'm going to show you what that is. But here, so they have this AUC, right? And they have combination of pathology images with clinical and molecular data enables the creation of accurate and reliable prediction models for cervical cancer. So here they say pathology images and clinical features. And here they say pathology images, clinical, and molecular data. So when I listened to the summary, it was important. So the actually pathology images and clinical features gave this AUC of 0.78. When molecular features were included, it went down to 0.6 something something. So they used molecular images and clinical for creating this model, but then when they were like testing which features and what was most important, actually pathology and clinical data was the strongest, with all these genes actually lowering the AUC. And I want to show you how I know this. Well, the best way would be to read the paper, but I do not have time to read full 5 papers, but I do have time to listen to podcasts about them. So I created something that is AI-based paper summaries. AI-based paper summaries are what the name says, AI-based paper summaries. So when you look at the Digital Pathology podcast feed in my podcast host, it's called Buzzsprout, you will see these episodes that they should have a padlock. Yeah, they have this padlock here, among other episodes. So there's a bunch, right? There's these that are like more downloaded and the ones that have a padlock. They are behind the subscription. This subscription is pretty affordable. It's $7 a month, and I'll show it to you in a second. But basically what I have is AI powered summaries of all these papers. So which one was that? The survival. It's the 216, episode 216. It's 22 minutes, and I listen to them at higher speed because they speak relatively slowly. So in like 11 minutes, you can have the content of this full paper for the price of maybe a Starbucks coffee. I don't know how much Starbucks coffee is because I don't have Starbucks in the vicinity, but like other fancy coffees definitely are going to be over $5. So let me show you that. First, you can check it also with the QR code. Why did I put it behind the subscription? Because it's AI generated. I don't want to have the podcast feed flooded with AI generated paper summaries. And this is for a very specific audience, which is you, my DigiPath Digest listeners, because you're interested in literature. So this is for you. If this is something you're interested to try out, try for a month and see if you like it. If you don't like it, great. If you keep liking it, fantastic. So you're going to have deeper insights into our papers. And now let's go back to the papers. Let me know your thoughts on that. If I know some people have already subscribed, which is amazing. So if you are here, if you subscribe to these AI summaries, let me know what you think. Because to me, this is like such a time saver. It's like, I don't know if there's any other tool or AI enablement that saved me so much time as the paper summaries to stay on top of what's happening in the digital pathology and medical AI literature. And now let's go back to our papers. Oh, this one was super cool as well. This one, and also I benefited very much from listening to the AI summary because there's a lot more depth than what we have in the abstract. And this one is titled Modern Pathology-Driven Strategies in Neoadjuvant Immunotherapy for Head and Neck Squamous Cell Carcinoma, from residual tumor quantification to spatial AI-based biomarkers. And the full paper has a lot of details. So if you are into immune oncology, spatial biology, tumor microenvironment, this one is for you. And I would definitely read it or listen to the AI summary as well. But what's happening? Neoadjuvant strategies in head and neck squamous cell carcinoma are reshaping therapeutic paradigms, shifting emphasis from anatomical staging towards biology-driven response stratification. So what's the neoadjuvant strategy? Neoadjuvant therapy is something being given before the surgery to shrink the tumor, to make it smaller, make the surgery easier. And here the transition from induction chemotherapy to immune checkpoint-based and combination regimes has transformed the perioperative setting into a translational platform that enables interrogation of tumor immune interactions and clone selection under therapeutic pressure prior to surgery. That's like a mouthful, but basically it just used to be induction chemotherapy that was supposed to shrink it, make it smaller, and now we are using immune therapy. And what's happening there, right? So in this context, pathological response assessment has emerged as a robust surrogate endpoint, overcoming the limitations of radiologic evaluation, which often fails to capture immune-mediated pseudo-progression and spatially heterogeneous regression. So what does that mean? You take you do radiology, whatever imaging it is, X-ray or whatever, and you check if the mass is smaller, because that's what you want to have before the surgery. And then you see that it's not smaller. So that's what they called pseudoprogression, immune-mediated pseudoprogression, because what's happening there, if you're using immune-modulating agents, immunotherapy, there's going to be a lot of stuff happening there. We want the immune cells to go into the tumor and basically fight the tumor. So it's going to fight while creating inflammation. Inflammation is going to come with edema. There are like four different features of inflammation. Calor, which is going to be hot, red, we're not going to see that. Calor, tumor, rubor, funcțioleza. Calor, hot, tumor, it's going to grow. So that's the pseudo progression. It's going to grow because there's going to be edema. So it's not going to grow because there is more cells. Well, there is more cells, but these cells are immune cells, and you're not going to see that in radiology. So they say pathological response assessment has emerged as a robust surrogate endpoint. Obviously, that is associated with taking a biopsy, right? But it's better to take a biopsy than to take out something that pseudo progressed and then look under the microscope and say, hey, it didn't really pseudo progress. You didn't have to take it out. So complex concepts, super interesting paper. It's a review paper. They developed this so-called residual viable tumor, and this provides a reproducible metric of therapeutic efficacy, while characterization of immune-related regression beds, tertiary lymphoid structures, macrophage polarization stages, and compartment-specific nodal responses. I'm going to explain that. So what do we have? Characterization of immune-related regression beds. So where we have a lot of immune cells, but not so many tumor cells. Tertiary lymphoid structures. So this is what's happening when immune cells come in. They organize. So in the lymphoreticular system, which is going to be your thymus, your lymph nodes, where the immune cells are supposed to be, like when nothing is happening, they're organized in specific formations, like round centers, follicles, right? And then when they come in to do something in the body where they were originally not present, they form these tertiary lymphoid structures, which also are like follicles. There's a definition like how big they're supposed to be. Also, macrophage polarization states. And these are things that we're not going to see on H&E. This is something where we need to do IHC or we need to do duplex immunofluorescence. So this is where spatial biology enters and meets oncology, and the digitization and digital pathology and image analysis is not an option anymore, not elective anymore. It is basically mandatory to understand all these dependencies. But macrophage polarization states, because depending like what the polarization state is, they're going to either promote the tumor growth or suppress the tumor growth. And that's happening in nodal responses, lymph nodes, where you can have micrometastases that kind of are protected by these macrophages polarized in a way that does not destroy cancer cells. So a lot of depth, a lot of spatial biology, a lot of tumor immune microenvironment. In this paper, they explain it, but long story short, these give them mechanistic insights into tumor clearance and resistance evolution. And there is evidence from phase 2 trials, single cell sequencing, spatial transcriptomics, and, as we said, multiplex immune profiling that supports the prognostic relevance of pathology-driven endpoints, which I'm going to put a heart here because pathology provides more information than radiology in this case. And being a pathologist, I'm happy about that, because usually you would consider, well, radiology is less invasive, but like the outcome of the radiological exam here, when you see pseudo progression, would be that there is a very invasive surgery, and instead you do a biopsy and check the pathological endpoints here. So integration of digital pathology and AI-assisted image analysis further enhances reproducibility and enables high-resolution mapping of residual disease and immune architecture. And this, within this modern oncologic framework, the neoadjuvant treated specimen functions as a dynamic biomarker platform guiding response-adapted surgical strategies and biomarker-driven clinical trial designs. And this was designed as a narrative review, so they did review different papers, but it is pretty thorough. I highly recommend you reading it or listening to the AI-powered summary. We're on paper 2 out of 5. Let's go to the next one. I think that was the longest. And now we have a classic in a new way, because every now and then we're going to have papers about Ki-67 and how it was used for like validating some image analysis. And I'm like, have I not read this Ki-67 paper yet? Because I think a week ago or a couple of weeks ago, we had something about Ki-67, but no, this one is new and has cool insights. So Ki-67 proliferation index in pulmonary neuroendocrine neoplasms, inter-observer agreement among pathologists, and comparison of 2 artificial intelligence-based image analysis systems. So it's very valuable because often questions come up, oh, which image analysis system is better? And finding these papers that actually compare some commercially available algorithms in peer-reviewed literature is a nice find to guide your decisions. And what it's going to show us is also pretty interesting. This is, I think, a publication out of Turkey. So for these, so Ki-67 is not formally incorporated into the grading system of pulmonary neuroendocrine neoplasms. So this is not like breast cancer where you have to do it. You can do it, and that's what they do. It is widely used as an adjunct marker to reflect proliferative activity and support diagnostic stratification. So Ki-67 is a marker of proliferative activity. And as we know, manual Ki-67, as we know, anything manual in pathology assessment is subject to inter-observer variability and methodological limitations. And this study aimed to evaluate the reliability and performance of 2 AI-based image analysis systems in Ki-67 index assessment, and to compare their results with expert pathologist evaluation, right? So like a classical setup, we have experts that used to do it, they still do it. This is like our standard of care. And then we have AI, we compare and we see, are they at least similar or good enough? Can we use AI and how, right? So we had 63 pulmonary neuroendocrine neoplasm cases, and there were typical carcinoid, atypical carcinoid, and large cell neuroendocrine carcinoma, and they were analyzed. And Ki-67 proliferation indices were independently assessed by 4 pathologists. So I'm already impressed. You've got 4 pathologists to do it for you. Amazing. Usually like getting 1 to do some work for paper is difficult. And they had 4, so this is good. And important, within predefined hotspot regions. Why do I know that it's important? Because I listened to the AI-powered summary. So they had this predefined hotspot regions counting approximately 2,000 tumor cells per case. 4 pathologists counted 2,000 tumor cells per case. Congratulations to the research team to make them do it for this publication. I am impressed. So the same regions were analyzed using 2 AI-based image analysis systems, Roche UPath Ki-67 and Verasoft Veracide Ki-67. So these systems basically count the Ki-67 positive cells, but they have like different ways of counting them. And in the paper, it's explained like how different they are in what they show. But when it comes to the results, and it like the way they work, the AI powered systems is going to be important to you if like you want something that works like you. So one of them, and I don't remember which one, was that it was just doing a binary call positive negative. The other one was like grading, high intensity, medium intensity, low intensity, and you can kind of set your threshold. There's always like those so Ki-67 is a nuclear marker. There are always these nucleides. They're like grayish, bluish. You don't know if they're positive, but they're not like super negative. So you have to decide on your threshold, right? And not only am I impressed but I'll tell you in a second, that they have 4 pathologists. They actually agreed very much. So they were evaluating the inter-observer agreement, and they also took into account domain shifts. So slides were digitized using 2 different whole slide scanners, Ventana DP600 and Leica Aperia 82. And they used color normalization and quality control procedures were applied prior to AI-based analysis. Nice work. They took care of potential sources of bias, and the Ki-67 indices were stratified into categorical groups based on tumor subtypes specific thresholds. So we have thresholds that are specific to these different tumor subtypes. So there was low, less than 10%, 10 to 25% was intermediate, and over 25 was high. And then agreement between manual and AI-based categorical scoring was evaluated using Cohen's kappa coefficients, and the results were that the Ki-67 proliferation indices varied across tumor subtypes, which is to be expected. Typical carcinoids showing low, atypical, intermediate, and large cell neuroendocrine carcinomas, high proliferative activity. So then we have like tumor biology. Okay, some subtypes have more proliferative activity, some less. But listen to this. The inter-observer agreement among 4 pathologists was excellent. It was 0.998. Like, can you imagine 4 pathologists counting 2,000 cells and they had this agreement? I'm impressed, because usually you're going to come across something like 0.7, 0.8 maybe. And here, almost perfect. But how were they so perfect? Well, we did have the predefined hotspot regions, right? You're not going to have that in your normal workflow. And they did count the cells for real for the publication. Usually, I don't know how many you count. You should, but probably you visually estimate. And that's how it usually happens. So strong correlations were observed between manual Ki-67 assessment and AI-derived indices. And there was 0.961 for Roche AI and 0.904 for Verasoft AI and 0.926 between the 2 AI systems. So they're both over 90% concordance with the pathologists. They're good enough. I would say they're good enough. So that indicates high concordance without systematic bias. Categorical agreement analysis using subtype-specific Ki-67 threshold showed excellent concordance between manual and AI-based scoring. So then also in this AI-powered summary, they're cool because there's 2 hosts, and one is always throwing wrenches into the conclusions or statements in the paper, and the other one is defending and explaining it. It's fun. I would give it a try. So this confirms the clinical interpretability and reproducibility of AI-based Ki-67 assessment. And Ki-67, I also want to say, it's something that if you want to introduce AI into your lab, if you want to gain confidence in these algorithms, Ki-67 is something to start with, because it's going to be used for every probably type of tumor, if not as official part of diagnostic guidelines, then as an adjunct marker, as they called it here. And it's pretty easy for AI to be good enough, and then easy for you to validate. but also gives you insight on how these tools work, how to integrate them in your workflow. I remember when I was working in a digital pathology company at the beginning of my digital pathology career, we wanted to create a Ki-67 tool to have a 510K clearance on that to enter the diagnostic test world, so to say. So conclusions: AA-based Ki-67 index assessment shows strong concordance with expert pathologist evaluation and reflects biologically relevant differences among pulmonary neuroendocrine neoplasm subtypes. And AA-assisted Ki-67 may serve as a reproducible and objective adjunct to routine diagnostic practice in pulmonary neuroendocrine tumors. Basically, they say it's good enough. They validate it. And I like these proof of concepts of classical things because it indicates that people are adopting, people are looking into it. And Ki-67 is a very good candidate to start your AI-powered AI image analysis journey, also for diagnostics. And if you want to learn more, then you can subscribe to the AI-powered summaries. But we are not done yet. We have two more. And if you're still listening live, let me know in the comments that you're here. It definitely makes me smile, and I like featuring you on the screen. Okay, so this one is I'm like every of these one is cool, and they really sound a lot cooler once you listen to the AA summaries. And now I stop repeating that. Let's focus on the literature. So molecular pathology, artificial intelligence, new technologies in hematologic diagnostics, translational opportunities, and practical considerations. So hematologic diagnostics is, I would say, underrepresented in these digital pathology papers, although there is a lot of algorithms for hematology. But let's look at this abstract. Diagnostics for hematologic disease rely on integrated assessments of clinical manifestation, morphology, flow cytometry, and molecular testing. And their current classification systems include the WHO HEM5 and the International Consensus Classification. I think they call it ICC later in the abstract. And highlight the central role of genomics in defining disease entities and risk. So genomics is important. And then at the same time, laboratories face growing case complexity and staffing challenges. Automation, collaborative robots, and it's green on purpose, also known as cobots. Did you know that word? I didn't know. I thought it was invented at USCAP when the executive from Ether AI, I interviewed him. Joe, I'm going to show you the video in a second. And he says, no, cobot is a collaborative robot. It's an official industry term. Then also, digital morphology platforms and artificial intelligence have begun to address these issues. With issues, the complexity of cases and staffing challenges. Here we examine the application of technologies in hematopathology and molecular diagnostics and consider their translational potential to improve diagnostic accuracy and ultimately patient care. It's so interesting because in every other paper, you're going to have this improved diagnostic accuracy and ultimate patient care. And when you go to the conference, all the manufacturers have to be super cautious about making these claims. So often you cannot use these words when you are in a real life setting with a device that is research use only, does not have the necessary clearance, whereas every other paper is improve diagnostic accuracy and ultimately patient care. But it's not a medical device. Paper is not a medical device reviewed by the FDA. It's peer reviewed by peers, right? So, a review of peer-reviewed literature and technical reports published through December 2025 was performed, and they were focusing on digital morphology platforms, AI for peripheral blood and marrow interpretation, AI-enabled flow cytometry, automated and robotic deployments in clinical laboratories, and machine learning applications in molecular hematopathology. So the important thing here that does not come across in the abstract is that they reviewed, and they will tell you specific company names in this paper. So if you're looking into solutions for hematopathology, definitely look into this because they mention specific automation platforms, specific scanning platforms, specific AI platforms. You can actually go and look up these companies and call the manufacturers if you're at the point of your hematopathology journey that you want to introduce any of these technologies. And if you are, let me know. And the results here were that digital morphology analyzers show strong concordance with manual microscopy and now serve as efficient platforms for AI-assisted differentials, cell classification, and fibrosis quantification. I don't know why they quantify fibrosis. Like, I don't know how you quantify fibrosis on a smear, but I bet they explain that. Deep learning applied to multi-parameter flow cytometry achieves performance comparable to expert review in distinguishing mature B-cell neoplasms and acute leukemia. And here, automated solutions, cobot systems, and robotic arm-based slide scanning clusters have demonstrated substantial gain in throughput and pre-analytical consistency. We're going to get back to this one. And the AI models in molecular hematopathology increasingly assist with variant interpretation, genetic risk stratification, and linking morphologic and genomic findings. So the conclusion is AI is beginning to change how hematopathology and molecular diagnostics are practiced. And successful translation will depend on disease-specific validation, always disease-specific validation, the development of multimodal models aligned with ICC and WHO frameworks, and laboratory governance that maintains expert oversight. And let's look at the cobot. Let's look at the cobot. And I'm going to tell you what it means. Well, it's collaborative robot. What does that mean, collaborative? You can like interact with it. Let's go back to our papers. We can do it. And then we can celebrate Easter. I think it's going to be the last one. Oh, this one is cool as well. I know, I say it before every paper. This one is cool. This one is cool. Yes, I chose them because they were cool. Hey, I did it on purpose. I chose the cool ones. Quantitative regression of qFibrosis with resmetirom, exploratory histologic endpoints from the MAESTRO-NASH phase 3 clinical trial. So important things is we have a phase 3 clinical trial, we have histologic endpoints, and we have a drug, right? Obviously, it's a clinical trial, so they were trialing a drug. So we have like very close to reality research experience, right? We are still trialing, we are still trying to prove that it's actually working, and we have histologic endpoints. I think, yeah, they were exploratory. So they were checking if they're granular enough, good enough. And we already had an example of these histological endpoints with the head and neck cancer, where we wanted to avoid pseudoprogression and needed to look at pathology. And here, this one is kind of complicated what they evaluated on histology, but the AA part summary explains it very nicely. So let's have a look at the abstract, though. Resmetirom, a thyroid hormone beta agonist, has been shown to improve metabolic dysfunction-associated steatohepatitis, MASH, and fibrosis in patients with non-cirrhotic MASH in a phase 3 serial liver biopsy study. So serial biopsy studies, you take a biopsy at the beginning of treatment, then at certain points, I don't know what their points were, but basically you compare what's happening in the tissue throughout the treatment. And the impact of resmetirom compared with placebo on histologic fibrosis features was evaluated using AI-based digital pathology, qFibrosis, in the phase 3 MAESTRO-NASH trial, which I love it because they are evaluating an AI-based tool in the clinical trials. They are doing it as an exploratory endpoint, but hey, let's check the results, right? So the methods, first, let's check the methods. qFibrosis was a secondary analysis of liver biopsies from 966 patients, a lot of patients, with biopsy-confirmed MASH and fibrosis stages F1B, F2, and F3 enrolled. So there's probably a definition, well, probably, of course, there's a definition what these stages are, and we would have to go to that, back to that definition. I don't have it right now. It was a multi-center, double-blinded, placebo-controlled phase 3 MAESTRO-NASH trial, and biopsies from baseline and week 52. So here, this is the like serial biopsy, were assessed using second harmonic generation and 2-photon excitation fluorescent microscopy. And the pre-specified assessment according to treatment was conducted of qFibrosis continuous values. So QFC are the continuous values, categorical stages, QFS, the stages, and Q statosis. And post hoc assessment were conducted of regional qFibrosis features and 30 clinical outcome associated qFibrosis features, including correlations of the 30 features with pathologist assessment, fibrosis improvement, and non-invasive tests, right? So we correlate this histology endpoints with other different endpoints, including pathologist evaluation. And we had different doses, 80 milligrams and 100 milligrams, and they led to the qFibrosis score improvement. It decreased by 1 or more in 24.4 and 22.3 more patients than in placebo, respectively, for these two doses. And then it reduced QFS worsening. So that was an interesting concept as well. Okay, it improved something that was bad, but it also decreased the worsening. Didn't progress so much or didn't get as bad as it could have gotten with placebo. And the mean placebo-corrected reductions in qFibrosis continuous scoring were minus 0.95 and 108, respectively, for the doses. Conclusion is that resmetirom treatment led to significant improvements in QFC, QFS, and individual collagen features associated with fibrosis progression. These digital pathology findings support the antifibrotic efficacy of resmetirom and demonstrate the potential of AI-based quantification to help define the fibrogenic response in MASH. And the impact and implications, this is the first evidence that AI-based digital pathology, including qFibrosis and region-specific collagen features. So region-specific collagen features, it's something that is important here because regions like microanatomic histologic regions where things are happening, not like the overall quantification, not like the size like we had in head and neck or anything, but region-specific stuff. In this case, collagen features, where it was immune cell infiltrates and the profiles of different cells, right? Sensitivity detects antifibrotic treatment effects of resmetirom in MASH beyond the conventional ordinal staging based on a phase 3 pivotal trial. And these continuous metrics highlight nuanced pathophysiological mechanisms of fibrosis progression and reversal in MAS-LD, including early matrix remodeling, allowing for more granular, reproducible, and biologically plausible analysis. I'm going to put the dot here as well, near biologically plausible, and the ability to quantify distinct collagen remodeling patterns, especially in portal tract and zone 2 regions, could help refine the understanding of the antifibrotic effects of treatment for MASH, including the impact to reduce fibrosis progression to cirrhosis and clinical outcomes. So this is a lot, a mouthful again, but what it's basically telling us, we have visual biomarkers that can be quantified by AI that give us a lot more nuanced information about what's happening with the patient and how the patient is reacting to the drug than the categorical scoring, which was the best we could have before. So now, unlike Ki-67, where you can like directly reproduce it visually, and if you're like good and diligent, you actually count these 2,000 cells, here you cannot do it. And it is taking us it has already taken us into the era of digital biomarkers. Digital biomarkers, what do I mean by that? Is biomarkers, visual biomarkers on images that these still can be confirmed by a pathologist. Like pathologists can tell you, oh yeah, it actually is in zone 2 regions, it actually is in the portal tract, and I see this remodeling pattern, but they cannot visually quantify it. So you need a tool to quantify and put all these features together to be able to derive insights from this, whereas pathologists can describe it, can see it, and that makes it a super cool tandem, super cool collaboration, a good collaboration of the pathologist and the machine, where you have the expert in the loop confirming, verifying that the quantification is of the right things. So that's what happened in this clinical trial, and it happened in a clinical trial, which gives us even more real life validation. If you want to dive deeper into these abstracts. The next step is going to be the AI-powered summaries. The QR code is on the screen right now for you. We have a promotion, Easter promotion for the store. So here, code to the store is in the left corner, and there is a code, promotion code. So if you go to the store and you at checkout use the code Easter25 on anything that is in the store, you're gonna get a 25%. So if you have been like on the fence whether to take the AI course that's there, now you're gonna get a 25% discount. Or if you wanted earrings, here, the ones I'm wearing for every conference, or whatever you see there in the store, everything is discounted by 25% until April 8th. So take advantage of that if that was something you always wanted to do and now you have some time. It's gonna definitely save you time versus doing it yourself, like digging up other resources. Thank you so much for joining me. Thank you so much for staying till the end. I'm going to be popping up in your inbox and I'm going to talk to you in the next episode.